I'm Curtis Lachowiez. I'm a third-year medical hematology oncology fellow at the University of Texas MD Anderson Cancer Center. I had the pleasure of presenting our group's updated analysis of the completed phase 1b portion of our study of the IDH1 inhibitor ivosidenib in combination with the BCL2 inhibitor venetoclax, with or without the addition of azacitidine in patients with IDH1 mutated myeloid malignancies. This trial has previously been presented, at least interim results of the phase 1b portion. We enrolled patients with high-risk myeloid malignancies with a confirmed IDH1 mutation. This included patients with newly diagnosed AML, which was comprised of patients with treatment-naive de novo AML, as well as patients with secondary AML or treated secondary AML evolving from an antecedent hematologic disorder, as well as patients with high-risk myelodysplastic syndrome or myeloproliferative neoplasms. Patients were enrolled into one of 4 dose levels. There were 2 doublet dose levels, combining ivosidenib with venetoclax 400 milligrams or venetoclax 800 milligrams. The reason for the escalated venetoclax dose is that ivo is actually a CYP3A4 inducer, which increases venetoclax metabolism and reduces its plasma concentration by approximately 50%, hence the 800 versus 400 dosing. And dose levels 3 and 4 enrolled patients with the same doublet doses, but with the addition of azacitidine. Overall, we saw that both the doublets and the triplet regimens were highly effective. The overall response rates for dose levels 1 through 4 were 67% for dose level 1, and then 100% for dose levels 2 through 4. Composite complete response rates across the dose levels were 67%, 100%, 85%, and 100% respectively. We also saw robust responses when evaluating the patients by disease group, irrespective of whether or not they received the doublet or triplet regimen. Though the numbers are small, patients with de novo AML that were treatment naive had a composite CR rate of 100%, as did patients with myelodysplastic syndromes or myeloproliferative neoplasms. Patients with secondary or therapy-related AML had a composite CR rate of 80%. Overall, both the doublets and the triplets were well tolerated and safe. The most common adverse events included febrile neutropenia, which occurred in 29% of patients, and lung infections or pneumonia, which occurred in 19% of patients. There was no 30 or 60-day mortality on the study. We also evaluated whether or not the doublet and triplet regimens were resulting in changes to the clonal hierarchy of the patient's leukemia using digital droplet PCR for IDH1 in remission. What we observed was similar to data that was presented in the IVO-AZA trial that recently was reported. Patients that received 5 or more cycles of therapy had an IDH1 clearance rate of 64%, and we observed clearance of the IDH1 mutated clone across different disease states, meaning patients with newly diagnosed AML, MDS or MPN, and relapsed and refractory AML. The overall survival has not been reached. Median overall survival has not been reached for dose levels 2 through 4. Currently, overall survival appears most favorable in the triplet cohorts, with a 12-month overall survival of 85% in dose level 3, and the median follow-up was not quite long enough to calculate a 12-month overall survival for dose level 4, but at 11 months it was 100% within that cohort. When we analyzed survival again by disease group, we observed a 12-month overall survival of 79% in patients with newly diagnosed AML, 100% in patients with MDS or MPNs, and a more modest 12-month overall survival of 50% in patients with relapsed and refractory AML. And this is fairly mature follow-up. The median follow-up was 24 months or 2 years on study. We also evaluated outcomes based on measurable residual disease as measured by multi-parameter flow cytometry as opposed to IDH1 clearance. Patients that cleared their MRD in remission had a 24-month overall survival of 100% compared to those that were MRD positive who had a median overall survival of 8 months. Though the numbers are small, so it was not statistically significant, more patients treated with the triplet regimen, 75%, achieved MRD negative remissions compared to the doublet regimens at 50%. For that reason, dose level 3 dosing of ivosidenib with venetoclax 400 with the addition of azacitidine has been selected as the recommended phase 2 dose based on its efficacy and toxicity profile and its activity that was observed, and will be moving forward into the phase 2 expansion cohorts.